And I guess my simple mind, in community oncology, we have to distill things down into why, why do we do this? Because I have to explain it to a patient, right?
Well, I do the same thing in my practice, and I just usually, we fake it. No, I'm kidding.
Yeah. But I mean, in my simple mind, why perioperative chemo would make better sense than chemoradiation would be higher dose chemo up front, eliminating micrometastatic disease.
Concur.
Before surgery, because once you go to surgery, it's kind of a long wait.
It is.
And
it is.
Things can grow up and seeds can become plants.
Agree. Yeah.
And
I think
that's my simplistic understanding.
That's my understanding too.
Okay.
So again, we see eye to eye, even though you're taller when we stand up. But the idea of systemic control versus local control, I think, is one other way, another paradigm where you can place the understanding of this.
Yeah.
So systemic therapy is systemic micrometastases, and local therapy is surgery or radiation.
Yeah.
Basically. And which of those compartments are responsible for the lower survival?
Mm-hmm.
And I think what we learned from perioperative surgery chemo is several things. One is that systemic doses of systemic chemo, because the doses in CROSS are low weekly doses of Taxol platinum, are important. They still have a pass CR rate of around 10 to 15%, I think, in Isopec.
Mm-hmm.
But then if there are any stragglers behind after surgery, you have this adjuvant. I call it an insurance policy when I talk to my patients. So you debulk systemically, you get rid of the systemic micromets, you take out the source of the mets, and then you give something afterwards to finish the job.
Yeah. And then, this was very quickly followed by a couple studies that read out, Keynote 585 and Matterhorn.
That's right.
A little bit of difference in design between those two studies. One was negative, one was positive. The positive one, of course, changed practice.
Yes.
Yeah.
The advent of DFLOT. As Dr. Klempner said in his very excellent
got a lot of applause for it.
Oh, my goodness.
People love a good acronym.
Yeah, he got a lot of applause when he said, I'm going to name it DFLOT.
Which he deserves.
I guess. It's kind of like maybe if you're an astronomist and you want to name a star after your dog or something. But whatever finds interesting. But I will say in all seriousness that, I'm going to geek out a little more, but you guys know me, so it's no surprise. And since I've been doing this job, when I trained with Arlene first year in the 2000 early aughts, we had 2 in a row plenary sessions for esophagogastric cancer. 2 in a row. Okay, we can end here. Drop the mic.
2 in a row.
No, so Isopec showed that perioperative chemo is superior to preoperative chemo-RT, and that shifted practice hugely because so many folks were using CROSS, including ECOG, right? That was our backbone regimen for studies like for EA2174 that Jennifer Eads is running. But also the second one was Matterhorn, which is, oh my goodness, immunotherapy works in the upfront setting. What a gift.
I know.
But it is, it's a blessing to have that data. And I like the DFLOT, the DFLOT name quite a bit. There are some caveats or points to be mentioned about Matterhorn if you wish. We can also talk about what we might consider down the road to make things even better.
Yeah.